for your attention. Have a nice day.
Yeah, thank you again. And please, yeah, the next presenter, Bolashak Tajmuhan. Yes, in the meantime, if I try to access it again, well, I think it's better to download it. Yeah, if you can take the yeah. While you're opening it, so open it.
Hello everyone, my name is Kazakhstan. I'm a surgeon. I have graduated Kazakhstan Medical University in 2018. After graduation, I've been working as a surgeon in rural clinic Kostanay region, and then I had a practice working in Atrao and 2 years in Almaty, and then for that period of time, I noticed that we have enormous problem with mini invasive surgery like laparoscopic and robotic surgery, because if we live in big countries like big cities like Almaty, Astana, Shymkent, we cannot understand it because we have access to getting this treatment. But when it comes to going out 20 kilometers from big cities or centers of provinces, it's going to be difficult to get access to these operations, because even until now, in our country, we are doing operation with open method, big incision, a lot of days of hospital day staying, and then a lot of long recovery time, and then what else? It's difficult. It means we need to start to do laparoscopic and robotic methods of operation ubiquitous, like what's widespread everywhere in our country. Because when it comes to here, after coming here, I noticed that it is usual thing. For implementing it, we need to modernize our surgery in Kazakhstan for healthier future. In order to implement it, I think we need to create the association KSIS. KSIS is Kazakhstan Surgical Innovation Society. What is this and why we have to create it? Because to improve the quality of surgical services provided, reduce the risk of complications of surgery, make laparoscopic and robotic methods of treating surgical diseases as widespread as traditional open surgery, as I said before. Create a competitive and a more qualified group of surgeons with advanced surgical skills in Kazakhstan. What is minimal invasive surgery? This is modern interventional method of performing surgical treatment. Rapid recovery time after the procedure. Smaller cosmetic impact and fewer scar. Economic benefits. Higher bed turnover rate per year. It means more patients and less bed days, hospital bed days. Less external aggression on the patients, overall the body. Opportunities for access and manipulation, smaller and more vulnerable anatomic structures like bile duct system and so on. And improved surgical precision and reduced risk of complications. What is the state of minimal invasive surgery in the UK? In the UK, they are doing a lot of operations laparoscopically and robotically in these areas. They are doing laparoscopic and robotic cholecystectomy, appendectomy, a lot of types of amputational operations in all of these fields. And all of these listed procedures are carried out in almost all multidisciplinary clinics. What is the state of minimal invasive surgery in Kazakhstan? All previously listed surgical manipulations are also carried out in Kazakhstan. but only in large cities such as Almaty, Astana, Karaganda, Aktobe, Shymkent, and so on. This causes a huge problem for rest of the population in the outskirts and provinces, delaying the process of surgical treatment. Postponing surgery due to long waiting lists it can be results in more complications. Then, as regard to robotic surgery, the United Kingdom has approximately 125 Da Vinci systems in use across various NHS and private hospitals. The UK has one of the largest robotic surgery programs in Europe, utilizing this system for a wide range of specialties like urology, gynecology, thoracic surgery, cardiac surgery, and gastrointestinal surgery. The United States has about 6,000 Da Vinci robotic systems in use, ready for operation. When it comes to China, the adaptation of Da Vinci system is also growing rapidly. As of recent data, there are over 300 systems in use. It means we also has to be like them. What about robotic surgery in Kazakhstan? Kazakhstan has only 7 Da Vinci robotic surgical systems. It's not bad, but however, only 3 of them in use. Yeah. Astana, Almaty. Yeah, unfortunately, Astana, Almaty. Why is this? Is it like this? The first reason is lack of simulators. The absence of Da Vinci simulators limits doctors' ability to train effectively. One Da Vinci system with all necessary equipments costs about $2.5 million. This means that it's unreasonable to train doctors on such an expensive machine, which automatically raises the question on the need for simulators. Consequently, only 3 of the 7 available systems in Kazakhstan are currently operational. And next is, when it comes to laparoscopic surgery, many surgeons develop laparoscopic skills primarily through hand-on experience as surgical assistant, at best by attending brief training courses. Consequently, they often lack a comprehensive understanding of complexities of handling laparoscopic instruments. It means they cannot get access to training, to knowing what it is in studying period. They can understand it only after starting to work. It's dangerous. I don't know. Why the UK is better than us? Because British colleagues have very well established academic base in terms of laparoscopic and robotic surgery from the level of the medical university. And the next one is educational system. There are many systems for training students and resident doctors through an intercalated master's degree systems, membership laparoscopic associations, and many practical scientific circles. And then specifically created assessment system of minimum practical skills that required for surgeons to perform minimal invasive surgery, mentoring programs, proctoring programs, and quarterly, annually congresses and meetings for surgeons to share experiences in mastering robotic surgery and making adjustment to any problems that arises. As for me, when I started to work as a surgeon, we had enormous problem about sharing experience because our senior surgeons didn't want to share their experience. They saw on us like their competitors. They didn't want to teach us. We have to get rid from this behavior. We need to share. We have to create associations. This is a general checklist of all required skill for obtaining laparoscopic passport within the United Kingdom borders. Following this protocol, we also need to create our own system for monitoring the quality of skill acquisition. For instance, I want to say that 1 month ago, only I passed this exam from 70 students in the UK. Okay, yeah, thank you. And as you can see in this table, all the developed countries listed have their associations and standards of assessment of surgeons' skills to grant them certification for performing minimal invasive surgery. For instance, in USA, it is FLS. In UK, it's LSGBI, which I passed, which I said. And then we're Kazakhstan. This is, for tasks and skills for of them roughly practically same. For instance, in the UK, LSGBI need to know polo transferring skills, rotor knot doing, pattern cutting, and suturing skills. And in the USA, it's practically the same. It means it's not difficult to starting do it. What does Kazakhstan need to do? At least create mandatory requirements for mastering basic skills for all graduates of medical school in Kazakhstan. Establish a local equivalent of LSGBI and the certification standards granting the right to perform minimally invasive surgery. And make above-mentioned manual skills universally adopted among surgeons, enabling the conversion of many routine open surgeries to laparoscopic procedure everywhere. And after accumulation, a sufficient number of specialists with strong laparoscopic skills begin increasing the share of robotic surgery in major cities. At least one center in every each region: west, south, north, east, and central region. It means we can have access to everywhere laparoscopically, and in major parts of our country, at least 5 centers, robotic centers, because robotic center is expensive. How to implement it? Firstly, it's essential to establish centers equipped with advanced laparoscopic and robotic training simulators. Second is develop standardized guidelines, as I said before, and training materials tailored to Kazakhstan needs. Collaboration, partnership with countries experienced in minimally invasive and robotic surgery. And provide access to preclinical practices on dry and wet specimens, opening vivarium and experimental operating rooms. Introduce a specific scientific approach to clinical surgery. What it means? This means not only training doctors and students in these skills, but also conducting scientific research on the effectiveness of each skill, performing evaluation, sharing data with global community, and constantly promptly updating the requirements. And the last one is set up local production facilities for laparoscopic instruments to reduce costs and improvement accessibility. This is more likely second stage of my plan for development of the association, establishing domestic production of laparoscopic trainers and the training instruments within our country, and selling them to our neighbor countries, to Uzbekistan, Kyrgyzstan, like that, because they will be interested on us if we can realize. This is a preliminary emblem of our future association. This label was created by me and by my best friend ChatGPT. Okay. Okay. This is world map, highlights the countries with Queen Mary branches, the university where I am studying, marked by red dots. It also shows where the British Association of Laparoscopic and Robotic Surgeons affiliated with this university and is collaborating to advance surgical practice in these countries. Why not add another dot in our country? Okay. There are potential bases or universities where collaboration could be initiated. Why? Nazarbayev University, this is because, as is well known, Nazarbayev University follows a Western European education system, and the medical school is taught in English. This provides opportunity for easy integration with, for instance, Queen Mary. The second university is KSIS because it's convenient. It has research area and the simulation centers, vivariums, and it has well-equipped bases for creating experimental operating rooms. This is on the left side. This is ready-made laparoscopic simulator available on the internet at very reasonable price. The cost of the unit is maximum £400. From the right side is my existing simulator in Kazakhstan. This is a virtual laparoscopic simulator for performing a wide range of surgeries across different fields, including general surgery, gynecology, traumatology, and so on. After successfully mastering the essential basic skills in laparoscopic surgery, the student begins learning to perform surgeries on the virtual simulator, not on patients, real patients. It's prevent from troubles and, I don't know, killing someone like that. This is a robotic simulator that allows the development of skills and advanced and enabling the surgeon to perform operation on real Da Vinci system without the fear of causing any malfunctions and the complications due to surgeon's error. The cost of robotic surgery simulators can vary widely from $40,000 to $200,000. What about planning of these centers? A well-equipped center for 30 people, which cost approximately £25,000 for laparoscopic center. It's not expensive because for 30 people, and about £3 million for robotic surgery center. It's also not expensive because real Da Vinci system costs $3 million, and training center for 30 people costs equal. It's better. The full training course to master laparoscopic skills would take about maximum 6 months, while robotic surgery portion would require an additional 2 months maximum. Because after mastering laparoscopic skills, it's easy to practice in robotic simulator. It means you just need to get used to working with this machine. And as a result, each center can train at least 250 full qualified surgeons annually. This would significantly enhance the country's capacity for laparoscopic and robotic surgeons. What do we get as a result? A new wave of young surgeons in all areas, surgery, oncology, traumatology, and so on, who are fluent in laparoscopic surgery. And next, strong communication and exchange of experience throughout the country that will allow red flags to be identified in time and eliminated in timely manner. And then continuous improvement of the quality of surgical and medical services in Kazakhstan is vital, particularly in rural area, as I said before, where laparoscopic equipment often remains underutilized, even if they has them. This is preliminarily due to lack of experienced surgeons in regional centers. Despite the widespread availability of basic laparoscopic systems across the country, this remains unused or are insufficiently leveraged because of insufficient expertise and training. This creates a gap in surgical capacity, particularly in rural and district hospitals, where the demand for minimal invasive surgery could significantly improve patients. And next is universal access to high-tech quality medicine for all of the citizens of our country. And the last one is the most interesting and more beneficial, financially beneficial result is consolidation. A large number of experienced minimally invasive surgeons in Kazakhstan would likely attract attention from patients in neighboring Central Asia countries. This would boost medical tourism as patients seek high-quality, cost-effective healthcare, particularly for advanced laparoscopic surgery. This is in terms of second step of my plan. We can use these devices for producing lab instruments. And on the left side, up and down side, we can see device for producing metal parts of the instrument, whereas on the right side, there is a 3D printer for manufacturing plastic elements. Development of the manufacturing laparoscopic instruments can make it not only bank of knowledge, but also the main distributor of training simulators is in Central Asia. We can not only train students, we can also distribute instruments. Okay. Summarize. We have steps of development. In short perspective, up to 12 months, we need to establish laparoscopic training centers. In medium term, up to 2 years, we need to develop virtual laparoscopic training centers, launch robotic training centers, and integrate minimal invasive surgery into medical school curricula, and entirely establish Kazakhstan Surgical Innovational Society to oversee progress. And probably in long term, begin to manufacturing laparoscopic tools to ensure sustainability. Thank you for attention. Question?
So, Bolashak, thank
Yes.
you very much for making this crystal clear for us who aren't so familiar with the medical terms and stuff. So I also think that this presentation should be heard by the tops, like by the Ministry of Health and stuff, because slide after slide, I had a question, but you already give the information the next slide. So I'm only left with one question, like to get the real picture. What's the highest or the biggest risk, do you think, in your implementation in Kazakhstan? What do you think the biggest risk is?
Risk is becoming best in Central Asia.
Yeah, that's an opportunity.
Yeah.
I mean, the risk in implementation.
I'm joking.
I like your positivity.
Yeah. I think there is no risk because surgery is all surgery is risk. Because dying and the treatment is everywhere, every time is parallel in our field. Because of that, even if you read books, you can see that I've done about 1,000 operations. After that, I've killed about 300 of them, like that. Because of that, we cannot avoid from troubles. It's unavoidable. Because of that, I think we just need to start. It's not difficult, it's eligible, it's doable, it's not expensive.
Yeah, I also meant that, education and medicine, they're like the core things in every society. So in education, when you have such kind of initiatives, very nice, very clear, step-by-step plan, when those get to the tops, they look at you as like you're too optimistic and stuff. Mm-hmm. And the risk I'm telling is like we have lots of corruption, we have these gaps between bigger cities and stuff in order to promote whatever you're promoting.
Big problem for us senior doctors, not young doctors, because young doctors understand that we need to share each other information. Senior doctors don't think so. They think about only money. Sorry. That's correct. Because I had experience for 6 years. They don't want to teach you. Only, I think, 5 or 10% of them can teach you, can share with your experience. Okay, because of that, I think we have to attend more young surgeons. We have to start from curricula, invading to curricula of medical system, not from practical field of the surgery. I think we have to start from the baseline.
Absolutely. I wish you good luck. And I'm not a medical worker or something, but if I can help and my 5 points in there, I'll be happy. Thank you very much.
Вы сейчас это в Англии изучаете? В Казахстане подобное есть, да, у нас в программе обучения на бакалавре или магистратуре?
К сожалению, нет. У нас старая линейная система программы советская. Сейчас начали внедрять болоньевскую систему. Ну, я не знаю, это как-то немножко глупо. Там 2 недели анатомии, вот так. Не то, что там лапароскопическая хирургия, у них анатомию 2 недели проходит.
Ну вот, это, наверное, и говорит о будущем.
Поэтому надо начать с воркшопов. Да. Workshops, societies. we can be part of the curricula, but I think probably first time we will not be compulsory, mandatory. It's going to be for enthusiasts, I think.
А в целом процент, как сказать, не знаю, как правильно звучит по-медицински.
Отношение лапароскопических открытых операций.
Да, успешность или как-то...
Успешность везде успешна, потому что лапароскопическая операция очень... минимально-инвазивная, ты видишь близко, и все аккуратно делается, не грубо, не топорным путем, руками. Да.
То есть это гораздо лучше, да?
Намного лучше. Легче, быстрее, лучше. Стандартно, допустим, возьмем холецистектомию. Стандартная открытая холецистектомия, просто открытие и закрытие занимает 10-20 минут. А в лапароскопии там, вся операция 20 минут займет. Вы там соревновались, даже, можно сказать. Кто быстрее?
Вы в Астане где?
Нет.
Вы в Астане в каком медучреждении?
Я в Алмате.
В Алмате.
Частная клиника ХАК.
Частная клиника. Ну, чтобы знали просто.
Чтобы знать, где идут соревнования.
Спасибо большое за интерактивную презентацию. Я хотела бы спросить насчет, вы же сказали, это более легче, быстрее и безболезненно, и, видимо, пациенты быстрее восстанавливаются. А есть вот потенциальные риски для здоровья именно? Или...
Для здоровья риски есть, допустим, когда лапароскопически делаешь, например, если в брюшной полости, это получается, ты делаешь такой так называемый пневмоперитонеум, либо капноперитонеум. Наполняешь газом брюшную полость, чтобы создать пространство. Когда ты делаешь пневмоперитонеум, если ты передуваешь, слишком много надуваешь, происходит что? Разрыв диафрагмы, потом эмфизема, получается, осложнения хорошие. Может быть, допустим, у стариков, либо там при коморбидных пациентов может произойти такие заболевания, там, как, допустим, невыдерживание наркотических препаратов во время наркоза, там, допустим, фатальный, как получается, как осложнение идет. Но, опять же, вопрос, отсутствие академической базы, мы не понимаем, насколько много нам нужно вкачивать туда газ. Мы знаем примерно 10, но почему 10? Почему не 12? Максимальный предел какой? Вот я сейчас изучаю, и мне интересно, допустим. А когда мы раньше говорили, наши старшие говорили, должно быть 10. Все.
И для ребенка,
Нет критического мышления.
Да. Поэтому риски есть. Риски везде есть. Нет такого понятия, в медицине нет рисков. Медицина, наука не точная, к сожалению.
Хорошо, спасибо.
Консультация осталась.
Такая живая тема. Спасибо большое за презентацию. И у меня вопрос по Дринче. Если у нас их 7, почему работает только 3? Если вы знаете, конечно, владеете такой информацией. И другой вопрос. Может ли врач удаленно управлять ей? Потому что я видела, у вас была картинка.
Есть такое понятие, как телемедицина. Сейчас только начинают британцы его включать, поэтому нам пока рано об этом думать. Нам пока хотя бы надо начать делать. Вопрос ответ.
Возможно, да?
Да. Почему только 3 из 7 работают? Потому что у нас нету, я как говорил, тренировочных симуляторов. А глупо подпускать хирурга, который никогда не пробовал ею работать. Да, их можно тупо просто сломать из-за того, что ты не умеешь делать. Потому что есть такое понятие, как клашинг. 2 джойса, получается, 2 джойстика. Мы когда работаем, когда ты пространственно там не умеешь работать, ты начинаешь их просто тупо стукать без конца. А есть такое понятие, как фризинг. Потому что я уже пробовал работать с роботами. Очень интересно, очень классно, намного легче оперировать. И, например, есть такое понятие, как фризинг. Когда слишком ты близко 2 инструмента преподносишь, нужно фризинг делать, обратно вернуться на исходное положение, но аппарат не будет возвращаться. И дальше продолжать. Вот такие мелкие моменты, к сожалению, создают риски сломать этот аппарат. Это как министрлар келет, соларға көрсетеміз. Пакетіңа жоқ қой. Сондай. Почему? Потому что у нас нету рукастых. Если будут хирурги, которые умеют, у них будут руки чесаться. Они правдами и неправдами найдут способ, чтобы сделать эту операцию. Но, к сожалению, так как нет у нас симуляторов, тренеров, тренажеров, мы, к сожалению, не можем к ним даже подойти на близко 5 метров. Я роботом не оперировал, только лапароскопический.
Врач за рубежом может управлять?
Может, да. Ну, сейчас такой этический момент, и поэтому сейчас пока только начинают.
Yes, just wanted to continue in English. Thank you very much for your presentation. Very nice. I saw my 2 alma maters. It was very nice as well. So, actually, when you were answering to Islam, what I wanted just to highlight is that every surgeon holds their own, what do you call it, like tomb.
Yeah.
So,
First is good.
I mean,
Yeah.
it's normal. It's normal thing for the surgeons. However, my question is not related to the surgery. I'm sorry, about the like details about the surgery or something like that, because I know it. And laparoscopic surgery was, I don't know, I studied it a long time ago. So for me, it's not a new.
In 1991. In 1991.
Yeah, but I'm saying that I studied it a long time ago. So for me, it's not like a newest like that you're open. However, the plan is very nice. It's very good. And my question is related about vivariums. So you mentioned about it. Could you please clarify about that? Why you need them?
Yeah.
And what work is needed to be done there so that it will be correlated directly to the surgery?
See.
Thank you.
Thank you. When it comes to vivariums, I want to start to working with wet specimens like goats, pigs, because I think in order to start operate on people, every doctor need to start from trainers, then virtual simulators, it's dry part, and then to wet part. Because they need to understand what would happen with a live patient, in this case, goat and the pig. During your doing operation, what will happen after pneumoperitoneum? What will happen after putting the trocars? How to manipulate in the abdominal cavities like that, in order to more understand them. The second is vivariums can allow us to follow up after doing operation. Yeah? Я переживал насчет английского.
Yeah, why I'm asking, because here rises the second question.
Yeah.
It's related about the ethics.
Yeah.
It's related to the work on animals.
Yeah.
And etc. Why I'm asking, because I was working with the animals here. I have the license to operate on that, on some strains, on some species. And since, I would say, Western countries, they're now stricter the legislation, as well as trying to minimize the work on animals.
Yeah.
I don't know about the post-Soviet Union, I would say
No problem.
the plan about that. Yeah, so you're still thinking that it will be allowable?
It's gonna be difficult, I think, in terms of presenting of our results to, for instance, to PubMed, Cochrane, Scopus, because you need to show these parts of legislation. But when it comes to in real life, we have, for instance, a lot of homeless dogs and cats. Not like here, because you can catch one of them and start to operate.
It will be get out.
Yeah. But it doesn't work in UK. Okay, because of that. Okay, you said good idea, because we need to think about it legislation ways, because to introduce our researchers globally.
The last question, I think, from the audience. First of all, thank you very much for your presentation. I mean, it was just fascinating, and also congratulations with your lab pass certificate and,
Okay,
and the exam. Actually, I've got a question about the market side of it. So, if I and how it works, for example, here in the UK with Da Vinci's, just as a case. So let's imagine that I'm touching the wood, but if I got to the hospital with, I don't know, with appendicite. So how the access to it work for just regular people, like in public, like health system here? So is it just like, do I need to pay additionally for that,
No,
or it's like subsidized and covered by
It
the
depends on the approach of the doctor. For instance, it depends on this case. For instance, if you have just
the regular
beginning period of the appendicitis, it means they can do it robotically or laparoscopically. It depends on the, for instance, sterilizing period of the instruments. For instance, this day would be 5 appendicitis, but they have only 4 sets. It means they cannot do 5th operation laparoscopically. It means they have robotic system. They say, okay, we will do it robotic.
Why not? Right?
Yeah,
If it is available,
okay, yeah.
I see. Yeah.
Yeah.
And like the last question about like applicability of the Vincis in Kazakhstan.
Yeah.
So again, do you think it is still like from the economic standpoint worth like installing the Da Vinci's in regions like yes, given the not like high maybe population or the market available for that, or it's still
the main problem is we have not a lot of population in our country.
Yeah.
We are only 20 millions. It means we need to widespread our skills in Central Asia. If we start to do, if we start to get more quantity of patients, it automatically will start gather a lot of patients from another countries, and interest will be benefit will be because part of them will be by OSMS and part of them will be paid condition.
Yeah, makes sense. Yeah, thank you very much. I think that was very interesting for everyone. Yes, let's see if we have any questions from online. For the program. Any questions from online? So if not, so once again, ladies and gentlemen, Borjan Tajmohan, thank you very much. Yes, we wish you all the good luck and best with your initiative and and creating this.
I hope.
Yeah. So we're now moving on to having a lunch break actually. So yes,
A little bit shorter.
it's gonna be shorter. So we're gonna see you in 10 before 2, right? Yes. Yes, about 30 minutes. Yeah. Thank you.